skin surface area, like the thigh or leg, can give physiologic testosterone levels in blood that have relatively no peaks and troughs, because the reservoir of those small testosterone drops is in the skin, and relatively large reservoir. So the reservoir slowly gives testosterone to the systemic circulation. And while it sounds totally ridiculous that we're dripping from these little teeny tubes onto the skin and spreading it broadly with one's hands would give us stable physiologic levels, I promise you, if you'll try it and then adjust up or down based on blood levels, as we've discussed measuring, that you will find the sweet spot within the normal physiologic range for that woman. Whether she's on estrogen or not doesn't matter, as I've shown you, and it's really a lot simpler than it would appear and a lot more precise than it seems. So that's what I would answer. And those products are very widely available. I don't know if they're available in Ukraine or in other parts of the world specifically, but you can look, and certainly this is an option for most individuals, particularly in the first world.
We're nearing the limit of our time, but there are a couple of questions in the chat, and then I will get to Marianne, that have to do with, is there an age limit? In other words, do you have to stop this at a specific point? Somebody mentioned 60 years of age. What's your thought about continuing this for how long?
So I don't have a cutoff. Everyone ages differently. Obviously, if one is using this for sex and they don't have sex, or they don't have self-sex, then maybe they don't need it for sex. But my point here is everyone's individual, and we should individualize care. I used to think that 60 was ancient, but now that I'm a decade and a half past 60, I think 60 is young, and everyone, as I said, ages differently. In my family, at least the men and the women both live to be 100 or past 100 years. So 60 is just barely past the midway point. And so individualization of that question, I think, is important. Why are you using it? Does that reason still exist? What if I go off? What is the downside? And how long or how old is that patient?
And Marianne has her hand up.
I do believe Sirarat was before me, but I'm not sure how strict.
I didn't see any other hands.
Okay, I'll continue. I have a question for the women. We know that approximately.
Where are you from?
Excuse me?
Where are you from?
I'm sorry. I'm from Norway. There's a nice summer outside. I'm sorry for the dress I'm wearing. But my question is, we know that approximately 50% get effect of getting testosterone on libido. And then I'm wondering, we increase the dose, we start with something, we increase the dose. Where do you say, no, this is not working for you, you shouldn't use this?
So I think this is a very important question and goes far beyond hormones. If we're using this for low libido or any of the other endpoints, as I showed you in that pie chart that was given to me by Dr. Lieblum, hormones represent a very small piece of the big pie. And all men and all women are very complicated pies, and those complications change over time. They change with the season, whether you're from Norway or you're from southern Chile. The seasons are different, and the seasons of our lives are very different. So if a normal level of testosterone is not working for the endpoint for which you're prescribing it, go back to the pie chart, go back to the bigger picture, look at her circumstances and try and get her to have some open dialogue, either with you or with others, about what her problems are and what circumstances are related. I've vacillated in my growth as a practitioner. As a young doctor, I thought everything was hormones and biology. As an older doctor, I think everything is really not hormones and biology, but by and large, circumstance, environment, age related, etc. And I am positive the truth is somewhere in the middle. So if it's not working for your patient, take a step back, try and understand why, try and understand whether the patient's goals are realistic. That's another thing. We think that hormones are going to make this 65-year-old woman like she's 20, and that is not going to happen in your life or mine. And so I have these unrealistic expectation patients all the time. And sometimes it's a big problem. She's 60 and she's dating a 25-year-old guy, and she can't keep up, and I can't help that.
So we're past time, but Sarat, I will let you have the last question.
Thank you.
Jim, keep it brief.
Yeah.
Okay, thank you for your very nice presentation. And I have two questions. The first one is is there a role of local testosterone in management for GSM? Because we know that we have the intravaginal DHEA available, but not local testosterone, even though testosterone is a downstream metabolite of DHEA. What is the rationale behind this? And the second one, as you mentioned, that the testosterone, when we add into the estrogen, is maybe benefit for bone, muscle, or body composition. So I think I'm not sure that means the tibolone or adding the systemic testosterone is maybe the good option for this context.
So very briefly, there is some data on intravaginal testosterone, and one can easily understand that the vaginal epithelium in its deeper layers, which are muscular, would respond like systemic striated muscle and improve contractility, maybe continence, etc., as well as sexual function. And this has been demonstrated preliminarily with DHEA, which, as you say, can be metabolized to testosterone. The problem with testosterone studies directly in the vagina is that estrogens and testosterone don't stay in the vagina. The vagina is an incredibly absorptive surface. And now we have the complication of whether those systemic absorption of those estrogen or androgen or both are in fact what the cause is, working in the brain rather than in the vagina per se. But yes, DHEA is documented to have beneficial androgenic effects on the tissues and to a degree on the response in the vagina. I focused on the vestibule, which is often neglected as a testosterone sensitive part of the vagina, if you will, and often a source of pain in women, which needs treatment. But lots more research in this area is required, as with bone, cartilage, growth, well-being, mood, cognitive function, etc. And I hope that's the overriding theme, that we need to do much more research on this compound and endpoints.
So with that, I'd ask Erica to show the remaining slides that we need to put up. So to remind you about the International Menopause Society, our World Congress will be in Rio at the beginning of October. The Council of Affiliated Menopause Societies is 71, you can go back, 71 countries and societies that are involved. Menopauseinfo.org is for your consumers and is translatable into any number of languages. Our journal Climacteric, which hopefully you all get. Tons of free online education, and World Menopause Day is October 18th. There's a QR code here. And once again, the website is imsociety.org. Next slide. And just a reminder that we will all be in Rio. We hope to see many of you who can get there. It's September 30th to October 3rd. And with that, I want to once again thank Professor Simon for an excellent talk and a really robust conversation. And I look forward to seeing all of you next month. Have a great day, week, and month. Thank you so much.
Thank you.
Bye-bye.